the CHUM's Therapeutic Innovation Unit. There, patients who've run out of conventional treatment options are turning to experimental therapies, some being tested on humans for the very first time. From cancer to other serious illnesses, the goal is to buy time. Recent studies include everything from cutting-edge medications to unconventional treatments like fecal transplants for cancer patients, some of whom have gone into remission. No promises are made, but the unit offers hope through innovation, conducting over 120 trials since its launch in 2018. Let's now go to Dr. Rahima Jamal, Medical Director of the unit and a hematologist-oncologist at the CHUM. Dr. Jamal, welcome to the program.
Thank you for having me.
It seems like the Therapeutic Innovation Unit is all about hope. What is it all about, in your words?
Well, to me, it goes back to the idea that all of our treatments today started somewhere in a unit in a phase 1 trial where it came from the laboratory or from animal studies. And one day somebody brought it into human studies. So all of our treatments today, particularly in oncology, started somewhere like that. And so I'm always hopeful that in our unit we'll have the next treatment that's going to change the trajectory for our patients, going to make a big difference. So every time it's a bit like a lotto or going to the casino and you get addicted to it, that to the idea that someday you're going to win, and every patient is going to win through those studies.
And let's talk about those patients. How do you end up at the Therapeutic Innovation Unit? What types of patients do you see? How do they end up there?
So at the Unit for Innovative Therapies, what we do is that, we get referred patients. So we get referred patients from either neurologists or oncologists, depending on the type of disease. So we don't just do cancer treatments, but we do other types of treatments. So for every patient that has a doctor out there who has a disease for which the treatments have not worked out, who are out of standard therapies, particularly in cancer, those doctors can send a referral to us, and we'll assess if we have a clinical trial for those patients. So the best example, for example, is in cancer. If you have a patient, an oncologist has a patient for which he has tried all the standard therapies and is out of options, he can refer that patient to us, and we'll assess whether we have a clinical trial that targets his disease, and then see if he might be eligible. And if he's interested, he might be able to participate.
So patients that are out of options, they're looking for a new option. And I guess with that, there's hope, but there's also lots of risk. Why don't we talk about that side of things?
Absolutely. And that's what we do when we consent patients. We are very transparent and honest that for every 10 treatments that are tested, only one will come to fruition. Only one might change something or go forward in development. So it's a gamble for one thing. It's hope, but it's tempered hope. The probabilities are that treatment might not work out. And then there's the risk. So once you start a treatment for the first time in a human, you absolutely have no idea what might happen. And you can give an idea based on the mechanism of how the molecule works, but you might have surprises. And that's why 1 out of 2 patients might decide that they don't want to go forward with that option. And that's perfectly okay. Our objective is not to convince people to participate. It's really to give the option so that they can have that option in the province without having to travel.
So let me ask you if you could give us a story about a success story about someone with a particular condition and a new trial and how that played out.
So we've had I'll give you an example. For example, for immunotherapy, 10 years ago, when I came back from my fellowship, nobody with less than 5% of patients had immunotherapy. today, because of those phase 1 trials and because of the studies that were done, 1 out of 2 patients will get immunotherapy during their trajectory for cancer. And so that's only in the last 15 years that this new treatment has become standard of care in many cancers like lung cancer and melanoma and renal cancer, ENT cancer, so cancer of the ears and of the throat. So that's like a very concrete example of how clinical research can have a big impact, going from less than 5% of patients getting immunotherapy for cancer to 1 out of 2 patients in cancer clinic today getting that type of treatment.
We're with Dr. Rahima Jamal, Medical Director of the CHUM's Therapeutic Innovation Unit. Let me ask you, you were mentioning how sometimes for patients, the other options would lead them out of the province, right? If you want to get access to some of these trials, you've got to travel, you've got to go other places, right? So let me ask you about that, doing this type of stuff in Quebec and how the Quebec healthcare system handles that. I know there's sometimes issues about paying for experimental treatments. So how does that work?
So these are not covered by the public funding. These are studies that are done through funding. So the pipeline for those treatments comes either from industry or from universities, and there are budget associated with that have nothing to do with public funding. So whatever we do with trials, it doesn't take away anything from access for standard of care in the public system. So that's really important. We don't take anything away from other patients. It's a plus, not a minus.
It sounds like your work must be very rewarding. I don't know if you've got a word or two on that, on how rewarding your work is.
I think it's not just my work. We are a team of 42 people at the unit. What's rewarding is seeing every day how those people are invested, how hard they work, the relationship that they create with patients, the commitment that they have. They could be doing so many other things. These are brilliant people, nurses, coordinators, people in the lab, and they stay and they work in a common goal of getting those treatments to patients, and that's what's so rewarding to work with these people and to work with patients that trust us to start this journey with us, to give up their time when they're sick and when that time is precious, to trust in the process and to maybe not have a good outcome for them in some cases, but they will definitely help us understand more about cancer or about other treatments or other diseases. And that's a big ask of them, and a lot of them do it with a great deal of generosity.
This last question I'll ask you. Let me tell you, it's not. It can be a religious question or it can be a secular question. I'm a secular person myself, but here's my last question, and it's: do you believe in miracles?
I've seen miracles. They're very rare. Miracles can be defined in a lots of ways. I'm secular myself. Unfortunately, what we're trying to do is that we don't want an anecdote. We don't want a miracle. What we want is something that will change the future of lots of patients. A new treatment, a new trajectory, something that will have a meaningful impact for more than 1 or 2 patients. That's what we try to do.
I want to thank you so much for coming on the show this morning and sharing the story of the Therapeutic Innovation Unit with our listeners. I really appreciate it.
Thank you for the invitation. I have a great day.
You too. That's Dr. Rahima Jamal, Medical Director of the CHUM's Therapeutic Innovation Unit.